Hey team, welcome. This is week 2, and so I wanted to spend a little bit of time just giving you a little bit of info for this week. In cardiology, again, not the most difficult week to review contents, but it's kind of about laying the foreground this week and then knowing how to apply it a little bit later. So there's a couple things that I wanted to review, a few resources we'll look at, and some points for you to think about while you're going through this week's module. Also, this will tie a little bit to last week's module. Week 1, we were looking in the module among just kind of getting things out of the way. We're looking at cardiac A&P. So this will be a little bit of an extension of that. This video is technically optional, but I think it will help you. And this is along the lines of what I might discuss if we're meeting in person during our cardiac classes during the week. Okay, so let me move to our content page for our class. I wanted to move back to the cardiac. We're going to look at cardiac assessment. All right, great. So here's our cardiac assessment page, mostly as it will be assigned to you as you would see it for the most part, although it's my view. All right, so we've got some reading here. Notice the reading right now is from the ACLS book and the paramedic textbook. There's a little bit of anatomy in there, but it's mostly about patient assessment for cardiac. And then we've got a couple resources here in the module. So HuffBook isn't really a big part of our studying for the assessment block this week. And I know some of you are still waiting for your HuffBook to arrive. So hopefully that would be helpful to you. So what are we going to work on? So we've got a couple resources here. We've got a document pertinent positives and negatives for assessment. You should have seen this somewhere else. And although we're focused on cardiac, as you know, we don't get to know it's a cardiac call when we start. So we probably are, as we're navigating patients, going through most of these systems. So we'll look at how they pertain to our assessment. We've got our heart tones location image. So this is just an image that'll pull up in a moment that shows you where to listen for heart tones. We have a video, a brief video made by somebody else, Moses, I think, a pretty good video that describes how heart sounds work and what they mean to us physiologically. And then another video on doing a neck assessment. And I think most of that probably not new to you, but there are some technical pieces in there that are testable. Now, what I would do is in the next, this section, the next section, a little bit of the last section, you may have to go back to the last module if you need to. When you're working on the second assignment, which is I think cardiac assessment assignment or cardiac assignment number 2, the homework assignment, have that out as you go through these because it'll probably answer the questions as a worksheet style homework as you go, and then memorize those things because they'll be on the exam. All right, so before I get into this, let's open this up. We're gonna look at that in a minute. And what I'm pulling up here is our cardiac lecture from Human Systems. Now, you don't have to go back and watch the Human Systems video if you don't want to. You're welcome to. They're on my YouTube channel. If you can't find them, let me know. I'll send you a link. You do have the PowerPoint slides here as well. This is basically, I think, Module 1L1, which is the gross anatomy of the heart. And so I use this because I just want to kind of reflect you back to some things that we worked on last term. Or even before that, right? For you, y'all, yeah, it's been a lot. You've done a lot between now and then, obviously. But this is the heart section. So just waiting for this to load here. Bring it up again, maybe. All right, there we go. Okay, so bear with me. This is a little bit of a lecture, but it's more, orientation. So I'm definitely not lecturing on this again. Okay, so this is a picture of the mediastinum and all the things that are inside the chest, but most of the things that are inside the chest around the heart. And I start with this because I think in Human Systems, I'm like, this is all the stuff we're gonna have to learn, right? So certainly these structures should all be structures that you can identify at the end of this module. Once you're done with the anatomy section, you should be able to name every one of these structures, and some of them are respiratory. But the mediastinum with the heart inside of it and all the blood vessels surrounded by the lungs and all the airways and, separated by the neck and the abdomen, all that stuff is tightly packed together. Also, the nerves that are in this region don't do a great job of communicating directly like they do on the surface of the skin. So I'll ask a couple questions just to jog your memory, all right? So a patient is complaining of pain and you think it's associated with the heart. What type of pain do you think the patient is experiencing? Visceral, parietal pain, easy to point out and very accurate when the patient describes it, or is it more vague and uses very broad terms? Good, so the heart, because it doesn't have a lot of nerves going to it that are sensory for pain simulation, which we have lots in our skin, so we can tell exactly where things are because we have so many nerve endings. In the heart and in most of the organs, it's visceral nervous tissue. And visceral nervous tissue, visceral organ, describes nerves that are in areas, but not always able to accurately pick up these very specific differences and types of pain in local regions. And so instead of getting, I have pain right here, we get pain in this area. Instead of stabbing pain, we get, it feels like someone's crushing my chest, right? So that is partly because everything's so closely together and the lack of having as many nerve vessels sensing pain or sensing sensory inside the body. Those two things mean that it's hard for patients to tell us exactly what they're feeling. And when we hear their description, it's hard for us to narrow it down. So again, we get a call for chest pain. It could be many things. It could be respiratory, it could be cardiac, it could be trauma, it could be GI. And through our assessment skills, we'll narrow it down, hopefully, to at least the most pressing of those things, the most life-threatening of those things that we can actually do something about. Now, if the patient reports pain in their chest, say a heart attack, what type of pain would we say this is an example of? Okay, what type of pain is this an example of? The patient reports that they have pain, but instead of being right over their heart, where we think their pain is telling us it is, it's in their left shoulder and left neck. What type of pain is that? They say it's one area, they feel it, they perceive it in one area. We know enough about this type of pain that it's probably referring to an organ in a different area. How'd you get that? Referred pain. So referred pain, vague, visceral pain, all of those things make it very difficult for our body to be able to know exactly, or to send the right signals to a patient, and a patient to know about our body where exactly the problem is. It's all here, right? They have a problem somewhere in this area, and it could be medical, and it could be trauma, it could be cardiac, it could be respiratory, it could be GI, it could be nervous. There's so many variations that we have to use assessment to start narrowing it down, because the patient doesn't see the inside of their chest. They don't have the benefit of all the knowledge of pain types that we do. They just tell you what they feel. And often that isn't by itself enough to narrow down what is actually going on. Not to say that the OP-QRSTU assessment isn't helpful. It's very helpful, but you can see the challenge, right? So our assessment in cardiac is partly to narrow down that we're looking at a cardiac problem. And then once we understand that we're looking at a cardiac problem, make sure it's not the other things. Make sure it's not respiratory when they have chest pain, because it could be. Make sure it's not trauma in the background. And then once we are narrowed down and satisfied that, okay, it's not these other systems, we've narrowed it down to the cardiovascular system, then we need to ask more questions to try and figure out what is the problem in the cardiovascular system, right? That's the challenge of our primary and secondary assessment. So as you're looking at the list, the reading and the list of assessment components in the pertinent negative sheet, I want you to actively think about what are certain assessments that you can incorporate into primary assessment that maybe aren't required in primary, that are high value assessments. Now, high value assessments can be high value for multiple things. Here, we're looking at what is a high value assessment, meaning I do one assessment that can rapidly tell me a lot about the patient, right? Let me give you an example. Patient complaining of pain in the chest, discomfort, not just pain, but discomfort in the chest, may not be pain, might just feel funny. It's enough for us to want to qualify and ask questions about pain. Patients that have an injury to the chest, torso, all the way around, patients that have high abdominal injuries, patients that have problems breathing, any of those things, any complaint that I think could be associated with the chest, I'm going to listen to lung sounds in my primary assessment. Primary assessment doesn't include lung sounds always, right? Like it's if you need to. We always assess breathing, but we don't always assess lung sounds in the primary assessment. So for me, if those things are present in my patient's complaint, I'm listening to lung sounds. Why? Lung sounds is a very high value assessment, right? I can do this tactically saying, I listen to lung sounds early on. And if I listen to lung sounds and my patient says, my patient sounds like my lung sounds are, the patient has bronchi in the upper fields, rail in the lower fields. Once I get that piece of information, I can start excluding things, right? My chest hurts, all these things, respiratory, cardiac, trauma, medical, GI, nervous, all those are in this big box when I walk in the door. Now, when I listen to lung sounds, it may not tell me it's not respiratory, but if I hear those sounds, right? If I hear rales and bronchi, thinking maybe it is something with fluid in the lungs, I now could say it's probably not an asthma attack by itself because I didn't hear wheezing. So I got that off the table. I'm ruling it out, right? I could say it's probably not pulmonary embolism, because pulmonary embolism would be clear lung sounds, right? So lung sounds very quickly tell me a lot or exclude a lot of things about my patient. So in a cardiac patient, I might hear wet lung sounds if they have pulmonary edema from a heart attack, left ventricular failure, lots of stuff, right? But again, I don't know that it's cardiac when I start. So lung sounds is a good question. Asking about coughs is a good question, right? So I use that in my primary questioning. Although there's not really a primary assessment list of questions, maybe a sample, I'm starting my secondary assessment during my primary phase when I'm trying to put these pieces together based on what they tell me, right? So my patient tells me they've got a cough, or I ask about a cough because they've got a complaint here. Cough is a high value question too, because if I ask about a cough and they say, no, I don't have a cough, then that probably means that it's not pneumonia. It's not COPD with chronic bronchitis. You get the idea, right? If it is a cough, ask about sputum production, like what comes out, another high value question. Because if my patient says, no, I have no cough, and lung sounds are clear, then it's probably not those funky respiratory diseases and disorders that have abnormal lung sounds and produce a cough. You see how I'm narrowing it down. I didn't get rid of all respiratory, but I got rid of some of the major disorders from respiratory with 1 or 2 assessment. Also, although you may not think of it, PQRS-TU, if you can move that into your primary phase in cardiac assessment, medical assessment in general, there's nothing saying you can't do it. It can't replace the primary stuff, and it shouldn't delay you on seeing, but that's questions, right? Like I can ask for walking down the street, can chew gum and walk down the street at the same time. So multitasking. So if you ask what PQRS-TU, high value questions come from that, right? For example, patient says they have chest pain. You think it's cardiac. By the time you get to PQRS-TU, you've done a couple of assessments, you think it's cardiac. You ask the patient about time of onset, PQRS-TU, and their answers are along the lines of, it was made worse when I worked out outside, like taking care of the yard. When I sat down, it got better, and it lasts for less than 30 minutes. Okay, so with that information, I've already got enough to know this might not be angina, because this might be angina rather. This might be angina because I was doing something and then I stopped and that made it better, angina. I did something and this has happened within less than 30 minutes, angina. If the patient had said I was watching TV and I had chest pain and nothing made it better or worse, I was just watching TV and I felt like I was working outside, but I've been just sitting here watching TV and it's been going on for an hour. That sounds more like a heart attack. So again, those things are high value things because your patients may not always have a lot of time with you that they can answer questions. It might be that I have to ask these questions early because they're high value, but because if my patient goes unconscious, I won't be able to ask them later. So I can't ask everything, right? Because everything's at a cost of something else I'm not doing, but think strategically. What are the assessments? What are the questions that I should ask to help narrow down to cardiac? And once I know it's cardiac, what are the things I need to get out of the way first? And please don't go straight to I need an ECG, because an ECG is a small piece of the puzzle. We need all the other stuff too. All right, so the whole point of doing the assessment is to figure out, is it one of these problems or is it one of the problems in the greater area of all the other structures, or in, the other medicine? It's all of it together, perhaps. All right, let me scroll through another area I wanted to bring up for you. Now, this isn't necessarily just assessment, but it goes along with some of the stuff we looked at last week and prepares us for ECG monitoring. If it's helpful to you, if you're a visual learner, go back and look at some of the slides. Now, this is out of the textbook for paramedic, but it's also in your EMT basic textbook. It's the same slides we used actually in EMT basic when we taught this. Be able to identify which part of the heart has depolarization with each waveform. So in this, it's one picture showing step by step. When the SA node fires, that's the beginning of the P wave, right? And then as the electricity goes through the atria on both sides after the SA node, that's the rest of the P wave. The PR interval is where the AV node holds up. There's no wave, so it's literally AV node working is nothing. It's a straight line between the P and the QRS. We'll measure it and all those things later to get more details, but that's the idea. And then once I start sending electricity down, the Q wave is technically really just up here at the top. The Q wave is where we see the electricity going through the bundle of His, now into the interventricular septum and branching into left and right major bundle branches. And so that's really the Q wave. The R wave going up, if I'm in lead 2, and this is lead 2, an eyeball right here, the R wave going up is going to be electricity coming towards me. So that's electricity going down this interventricular septum. And then the S wave going down is electricity going up the walls of the ventricles, because our ventricles squeeze from the bottom up. They depolarize down the septum, so no squeezing happens. And then when the ventricles have electricity stimulated at the apex, going up the ventricular sides, that's when they squeeze from the bottom going up. And that's our waveform. So a couple of things previewing, you'll hear later, but will help you look at this, is that when you're looking at an ECG, orientation means a lot, because the camera angles of every lead, right? Every lead that you look at on ECG is a different camera angle technically. The camera angle is going to dictate how the ECG should look normally, right? Lead 2 is the lead that I'm viewing right here. And that's the view from the apex, kind of like right down the barrel of the heart. Now, coupled with this information, you should also know that when I look at the ECG, if there's a wave that goes above the flat line, the isoelectric line, a wave that's positive going above that line means it's electricity coming towards my view. If I see electricity going below that line, it means it's electricity going away from my view. So let's pause here for a second and kind of tie this to what you're about to go through in ECG in module 4 and 5. My eyeball is right here for lead 2, right? So it should make sense that electricity moving from the top towards the apex, the base to the apex, the top of the heart to the apex, that movement should mostly have positive lines. And so you can see most of these are positive lines. The P wave is electricity starting at the SA node and then moving down the atria towards my view in lead 2, right? My eyeball's right here, electricity, positive P wave. The Q wave is this little kind of wiggle where there's like a curve here. But aside from that, like the R wave is moving, it's positive in lead 2, so it's moving towards me. And the way that happens is going down the septum. The S wave is negative, it's moving away from me. It doesn't have to go below the line all entirely, but you can see the R wave peaks, the S wave goes down, that's electricity going away from me. So let me pose this question for you, and I'm assuming none of you know what an ECG machine works. It looks, I know some of you do, obviously you're working in the field, but just for this second, assume you don't know anything about leads. There's a lead that has an eyeball opposite lead 2. Lead 2 is what you saw in EMT basic. Lead 2 is what an ECG monitor generally displays on the first, with if I don't touch anything, should display lead 2. An AED shows lead 2. Unless otherwise, assume that what you're looking at is always lead 2 for our purposes. We'll look at more leads later, but for now, you're looking at lead 2. This is lead 2. So a lead that would be looking the opposite direction from the top of the atria down towards the apex, that lead would see things differently, right? Because again, the rule is if the wave goes up, it's moving towards me. If the wave goes down, it's moving away from me. So if I have my eyeball here and the SA node fires and what would be a P wave in lead 2, when I see that waveform from this angle, instead of a positive P wave, I'll see an inverted P wave. And that would be normal in that lead, right? Because if the electricity starts at the SA node and goes down away from me, my eyeball's up here, is going away from me, that should be a negative line. So the P wave would be upside down. When I got to the AV node, be just a line between the P and the QRS. The Q wave, if it's present in this patient from the lead, basically looking, essentially you're looking at basically from the right shoulder. From that view, from the top of the heart down, the Q wave would be up and not down. The R wave would be down and not up, and the S wave would be up and not down, and the T wave would be inverted. So if I'm looking in lead 2, if I've got my eyeball here, if that's what I'm looking at, and waves are upside down, that's significant, that's not normal. But there are leads that look at the heart backwards, and there's leads that look at the heart from in between. So if my eyeball was right here, I might see a wave that kind of looks a lot different than normal. If I'm looking at a lead that is like a precordial lead, a chest lead, and it lines up directly over the septum, I'm going to see some electricity from the AV node going down the septum coming towards me. And in the same wave, I'm going to see some of it going away from me. So I can end up with the biphasic wave here, where instead of seeing one line going up or down, because I'm looking at it come to me and go away from me, I see two waves. I look at a down and an up wave. So the position you're looking in is always important. You'll know on an ECG because they're labeled, but if it's not labeled, again, assume you're looking at lead 2, which is down the apex of the heart. Good, okay, so work through that, especially if you're a visual learner. A reminder, review these phases. I think I mentioned in my previous video for us all last week, at the beginning of the week, look at the phases, know what they do, but I want you to take a step further, right? So remember in the human systems class, I gave you these waves. I talked about the steps because we were learning it, but I did tell you that I'm going to use the same exact slides as are in pharm and cardiac. So now we reap the benefit of that. This is exactly what we'll find in the cardiac slides, right? So look at the phases. Here's what happens. Phase 0 is when everything starts. Phase 0 is the start of depolarization. Phase 0 has our sodium channel, technically fast voltage gated sodium channels open, so sodium rushes into the cell, and that causes our cell on the inside to become more positive than negative. Phase 1, sodium channels are going to close. Potassium's kind of leaking around here. Phase 2 gives us the plateau. So this is phase 2. Phase 2 is very important in cardiac medicine because phase 2, although the other phases are important, don't get me wrong, but nerve cells don't have this phase, right? Nerve cells don't use calcium. Cardiac cells and muscle cells use calcium. Phase 2 is when calcium channels open. Calcium being released is very positive inside the cell, and that makes my positive charge plateau and hang out for a little while. So that gives me the benefit of a positive charge over time. But during that time, that's electrically. Mechanically, what's also happening is the calcium is then going to go and allow myosin and actin to bind together. So review how those things happen as well, how actin and myosin bind together, how troponin and tropomyosin work, because that's clinically significant when we're looking at ECGs. We'll discuss it again in application, but review these components and so on. So go through phase 3 is calcium channels closing, potassium channels opening. Now we're trying to move. Phase 3 and 4 is essentially looking at repolarization. And phase 4 is basically the end of repolarization and the action potential. So that's the basic. You should come here already with that pretty well understood. Review it if not. Now, although I showed this to you in human systems, it was actually from the pharm class, but applies here. So this diagram shows the class of antidysrhythmics on top of a depolarization waveform sitting above an ECG. So this warrants some description. As you're working on the cardiology, the cardiac pharmacology, so I should have said the pharmacology, as you're looking at the AMP and in the background, you're refreshing your pharmacology knowledge, you do want to be able to tie these pieces together. So while you're refreshing yourself on what phase 0 is, remind yourself what drugs and which class that is. Now, it should come no surprise to you. And again, some students need this level to like drive it home. Others don't necessarily. So you manage it as you need to. But you do need to know that class 1 drugs like lidocaine, which the others are all class 1, obviously, but lidocaine is a drug that's in our scope, used every day on ambulances across the country for this class. So lidocaine I'll use as my prototype for 1B. But when you're talking about a sodium channel blocker, if you know that in phase 0, sodium channels open, we would know blocking it means that we delay the depolarization onset. If you talk about class 4, those are calcium channel, you can see where they all work. So review where these drugs work. And again, I provided you these slides in the past. If you're the type of student that needs this level of granular detail to understand and drive home these points, great. If not, I'm not looking for you to memorize the shifts that are going to happen, but what happens in these images is showing a picture of each drug class impacting the underlying depolarization waveform of one cell. Remember, when we're looking at these phases, this is what's happening inside one cardiac cell. All of these together at one time are happening, and that's what we see as our ECG, but this is one cell's impact. So if we're using a class 1A drug, which is a sodium channel blocker, you can see its impact on the action potential is to slow the opening and release of sodium into the cell. Doesn't completely stop it because we'd have to have a lot of that drug to do it. And if we stopped it, there would be no impulse. But the result of the sodium channel blocker in the ranges we give for 1A is to delay the opening, which means that we delay for this particular drug, we delay the whole depolarization cycle. So if I delay, that generally means that I might slow a rate down a little bit. And in this case, the delay is on the sodium channel side, but you can see it delays and even shifts when repolarization happens. So let's think of this like more realistically applicable. If I gave this drug to a patient and their heart rate, it probably is abnormally fast, to be honest with you, but there's more to it. But if it's an abnormally fast heart rate and qualifies, I give this drug. That will mean that every time that the heart depolarizes, and all the heart cells will do this, every time the heart depolarizes, it depolarizes more slowly, and it takes longer to repolarize than it would without the drug. And if I do that over and over again, delay and take longer to repolarize. Again, I can't depolarize until I repolarize. If I delay those phases, then I give time for the heart to kind of have a pause before the next beat. So that could slow the rate or maybe even get rid of the dysrhythmia. Now, not all of the class 1 drugs will do this. Class 1A works in this way. Class 1B, where lidocaine hangs out, doesn't do much to the impact of the sodium channels delaying, but the net effect of it is it shortens the period before repolarization. So in this case, repolarization happens more quickly than it would in a patient that doesn't have the drug. And here's 1C. 1C delays sodium channels more than 1A, but it doesn't shift repolarization. Repolarization with 1C happens at the same time that it would otherwise. It really just shortens the whole depolarization cycle. Let's look at some more examples. So class 2 is beta blockers. There's not really, it's going to impact more than just the depolarization cycle. These are the things that it does, but I'm sure you're aware we've covered beta blockers pretty well. Here's class 3. This is a potassium channel blocker. So potassium channels do have a slight impact on the sodium channels, because remember, when sodium channels are opening, potassium channels are kind of variably still a little bit leaky. They're called leaky potassium channels. So if we give a potassium channel blocker, it could still have a little impact on sodium, but not as much. Its main impact would be on potassium, and most potassium in the cardiac cycle is during repolarization. So you can see here, it makes our depolarization happen longer. Repolarization still occurs mostly as normal, but then depolarization occurs mostly as normal, but repolarization happens a little later than it should. So that widens the depolarization, means another beat can't come along, and so another way to decrease the rate that this is occurring. This is a picture of a class 4, which is calcium channel blockers. So it's working on phase 2. Phase 2 of our depolarization phase, the plateau. And calcium channel blockers have an impact on electrical, but then they're also going to impact the mechanical, right? Because if I block calcium channels from opening, calcium doesn't open to go in the cell to help depolarize and make that plateau in phase 2, but it also isn't available for contraction to occur as well. So mechanical and electrical happen independently, to say that if you have electrical signs, like you see an ECG, don't assume that there's mechanical with it. PEA is a good example of that, right? Where there's nothing happening in the heart, no circulation, no pumping, but there is electrical activity that even looks pretty. But that's an indication that they're not always connected, but they have similar things that connect them. So with the calcium channel blocker, what ends up happening is we generally will kind of prolong the phase of the depolarization. So you can see the shift over time here. But more importantly, we're changing the threshold that the cell needs to open channels. So membrane potential is the magic number that allows these channels to open. If we have enough of electrical charge in that area, it'll magically open it. That's like the key. It's an electrical key. If we mess with the membrane potential, we can either make it so that the channels open faster, or the channels open slower or take longer to open. In calcium channel blockers, we're making it so that the threshold basically is slower and takes longer to occur, which can be very helpful in slowing really fast rates. And so it's another kind of goal of giving these drugs generally is to get the rate perfusable. And in fast rates, they may be so fast that they're not perfusing because there's not enough delay in the ventricles to fill with blood. All right, so again, just to review, those slides have all been in our mix the last couple of terms. And again, I like to use the same thing. So you have not seen it, you haven't seen a different version along the lines that we're studying in one area or the other. You can memorize one and it should mean the same throughout. Okay. When we talk about blood flow through the heart, which is a big portion of the A&P section, and a big portion of assessment, because blood flow through the heart is what we're listening to. We're listening to the valves open and close, so blood flow makes that happen when we're listening to heart tones. But blood flow through the heart, just a reminder, happens in two different ways across the upper and lower pumps. So this is to show the bands of muscle cells all together that are associated with the atria versus the ventricle. The atria cells look, pretty straightforward as you would expect. They're two kind of upside down cups. They both squeeze from the top down, and that sends blood in the ventricles. Now, these are not, you shouldn't think of these as individual cells nor cell fibers, because it's not exactly the same as skeletal muscle. But the way they operate, because of conductivity, contractility, automaticity, rhythmicity, all the unique cardiac myocardial cell properties, because of those, there's a concept all or none in depolarization of these cells. Now, they're tightly joined together by intercalated discs in the anatomy of it. The intercalated discs increase the conduction from one cell next to another cell up to 400 times faster than other muscle cell types. So very helpful in cardiac depolarization. But because they're so tightly together, if one cell depolarizes and meets the potential and causes electricity to go through and then eventually squeeze and contractility, if that happens, because they're so tightly together, all of them should also depolarize. So generally, if one cell depolarizes, the whole heart will follow because of the unique properties. Now, when the atria squeeze, top down, all or none, makes sense. But the ventricles are a little bit different. The ventricles, remember, when they squeeze from the bottom up. That's why the valves going into the pulmonary circulation, the aorta at the top of the ventricles. But when they don't squeeze just like we show in the picture, like this, right? They don't like just collapse upon it. They ring like a towel because of the design and structure of this muscle band. So think of the ventricles ringing together and twisting around the intraventricular septum as an axis, twisting to ring the blood up and out as the ventricles squeeze, close, and we have ventricular systole. Here's a picture of the intercalated discs as mentioned. So these are muscle fibers in the heart. The muscle fibers here, except for the intercalated discs, look just like skeletal muscle fibers. The intercalated discs, though, are only in cardiac muscle. So they're absent from smooth and from skeletal muscle. And again, they bring the cells so close together that we don't need to cross over interstitial space to get a signal from one cell to the other, which happens almost every other cell that we've looked at, right? This allows one cell to directly communicate with the membrane of another, because what's really happening is this cell right here, if this is, let me assume that the arrow is the direction we're moving in for my explanation purposes, the cells that are in this space, when they depolarize, their membrane had to meet the membrane potential to allow sodium channels to open, and then that caused the next one nearby to have enough sodium and positive charge to allow that to open, blah, blah, blah. So right, went down that. This is as if it's just going through more of the same cell. It's not like it's two different cells when the depolarization happens. It's as if all the cells together share the membrane potential. So then it rapidly goes through all these cells to cause depolarization. These are the unique properties that we're going to be like thinking of in the background as we talk about ECGs, because all electrochemistry in the heart happens because of these electrical properties. Now, these electrical properties you could memorize as CARI or CARIES, as some of our ENT basic curriculum uses that acronym or mnemonic to help you memorize it. It doesn't matter to me what you use, but you do need to know these are the unique properties of the muscle in the heart. So not all of the heart has it. The atrioventricular separation between the atria and the ventricles, in fact, is made up of connective tissue, and the valves are made up of the AV valves are made up of connective tissue, and they don't have these properties. So that's why electricity doesn't go straight from the atria to the ventricles without going through the AV node, where the pause happens, because the AV node is a track of muscle fiber. It's not a wire, you can think of it that way, but it's a track of muscle fiber, myocardium, that goes and bridges the gap between the atria and the ventricles. And that's the only place where these properties are. So that's the only place electricity can go from the atria to the ventricles in a normal heart. So those are conductivity, right? That's an electrical chemistry property that muscle cells generally don't have. So for conductivity, for example, in skeletal muscle, it doesn't exist. What happens is in skeletal muscle is you have one axon, right? One axon, multiple terminals of that axon that are all talking to different muscle fibers in the same area for skeletal muscle. And this is the neuromuscular junction. So I'm not having this cell send the signal to the others. Each cell is getting an independent signal in skeletal muscle to contract by the extensions of the axon. Here, that's not the case. There's not a neuromuscular junction with every muscle fiber. It utilizes a neurohormonal junction. So we've got hormones and neurotransmitters doing that. But to send the signal, it will rely on conducting from one cell, stimulating the next cell nearby, conducting that electricity through, and so on. Automaticity is what generates those things like pacemaker cells, and it's our backup system. So automaticity is present in all cells, but we see it normally in a normal heart functioning at the ASA node firing. It has automaticity in its cells that generates its own beat, fast or slow, depending on the neural hormonal environment of the patient. And then the AV node can generate its own beat. The Purkinje fibers in the ventricles can generate their own beats as they need to as secondary and tertiary pacemakers. Rhythmicity is this idea that the cells are going to organize their electrical impulses in a rhythm that happens regularly. Now, that could be a regular or irregular rhythm, have a pattern or not a pattern, a normal or abnormal rhythm, but there will be rhythms. Muscle fibers don't work in the same way, right? Muscle fibers are generally, there are some that generate rhythms, like peristalsis is a rhythm just generated among the muscles of smooth muscle in our GI tract, but it's not the same mechanism. So really, rhythmicity is a property of cardiac muscle. Irritability and excitability can get mixed up a little bit sometimes, so I'll just kind of tell you my take on them. They're not the same thing. Both of them mean that in response to a stimulus, something will happen, okay? So let's start with excitability. Excitability is a normal property. Excitability means that once the cell receives the electrical conducted signal, once it receives the signal that all the other cells conducted to it, it will conduct it on, but it will do something in response. So excitability means that if it has the right things, and like oxygen, glucose, insulin, electrolytes, it has enough waste removed, pH invariant, if it has all those nice healthy things, if it receives the conducted signal, it should be excited and send off a beat. And that beat will cause depolarization and be part of the conduction cell along the cells down the line, and probably lead to contraction if everything is there. Irritability is similar, meaning it can cause a beat in response to stimuli, but irritability would be abnormal. So with irritability for right now, and again, if you don't know the background, we're going to learn it, but most of you probably heard of something called a PVC, premature ventricular contraction. Irritability is what causes a PVC. PVCs are generally caused by a lack of oxygen locally in this case, the ventricles, in the area of the heart, lack of oxygen, lack of electrolytes, dehydration. Those are the things that generally cause PVCs or ectopic beats, premature beats. The heart, the irritability thing here is that the cells recognize they don't have those things. And instead of just not doing anything, which is what most cells would do, it sends off a beat just in case, because it knows if it rests, the patient dies. I'm assuming it knows this, but it knows in some way, it has some mechanisms in it to say that if you don't receive a signal, right, if you don't receive a conducted signal, which would be excitability and sending off a beat, then you got to make your own up. And that's part of automaticity. But here, it's not good or bad necessarily. Automaticity is not good or bad. Here, it's bad. Irritability means that you have a problem and the heart is sending off beats to stay alive in spite of the problem, because of the problem. And that covers those. All right, almost done with this. Let's move through to, let's look at this set of pictures here. So this is a top view of the heart, as if you removed all the blood vessels on top. This is a diagram, but this is a picture of a cadaver's heart. And you can see these valves should actually be closed. The atrioventricular valves should be closed even during autopsy, but they are not closed because they have a bunch of scar tissue on them. So they're not flexible enough to line up and close off. These aren't you got a little incompetence there, but that's probably no big deal. But in these two areas in our semilunar valves, they look fine. They closed all the way. So here's a view of how these valves look, and understanding their structure, like how they appear, understanding their makeup, helps make it easier when you're trying to track blood flow and when they close and when they open, which is part of the assignment for last week. And you'll revisit in Heart Sounds this week. Here's a picture showing the papillary muscles connected to the chordae tympani, which are then connected to the valves, which basically hold the valves open when the ventricle is filling. In this picture, you can see the movement of blood flow between the AV valves, so the tricuspid and bicuspid, or the tricuspid mitral valve. And here's the semilunar valve. So the blood flow should basically catch the curved side of the valve to cause it to close, because these are circuits in which, for example, let me back up to the last one. When the ventricles squeeze during ventricular systole, it'll send blood up and into the blood vessels, and then the blood vessels valves will open. Once those valves are open, blood flows through, and when the ventricle relaxes, it creates a vacuum and draw blood back into them. And the curve of the valves in both places cause the valve to close back up. 1 second, checking the switch here. Okay, team, thanks, we're back. All right, so along the same kind of vein, vein, arteries, along the same discussion as we had before we took that brief pause about how blood flow ties to valves and blood flow tied to heart tones. This is just a reminder of an application of that. So in this image, we can see that there's an aortic arch. This patient, I don't know the details of the patient, I just kind of stole the image, but the image here shows a procedure in which they've received some dye in their blood that's radioactive response to the x-ray. Patient's probably in the cath lab. And when the patient has this dye injected, it will show the blood vessels that it enters into through the x-ray. So at the point in time that this photo was taken, it looks like a couple assumptions, but it looks like this is right after ventricular systole, right? The start of ventricular diastole. So you can see here the shape of the actual aortic semilunar valve outline. So in the background here, this is the heart tissue. This is the branch, the little bud that will become the left coronary artery. This will be the right coronary artery. And then this is the aorta branching up and going off, and we can see some of our major arteries branching off the aortic arch. So a reminder that when our coronary arteries fill, that's generally going to be during the diastolic phase, meaning the ventricles are relaxing. So for systole, ventricular systole, the ventricle squeezed, again, more precisely like this. It squeezes, sends blood through. That causes the aortic valve to pop open. Blood going this way will pop it open. The blood pops that valve open. Blood goes into the aorta now. Now, aorta had blood in it, right? Like, it's not like there's a big old airspace. It had blood from the last ejection sitting there. The new fresh blood pushes that blood forward, and the fresh blood goes through systemic circulation. When the ventricle relaxes at the start of diastole and opens up, it creates a vacuum in the ventricle. Technically, I mean, it's not like a vacuum, there's no air involved, it's all fluids, but it creates a vacuum. The blood will start to go back into the ventricle from the aorta, and that will catch would be more like this, that would catch the upside down cup view of these valves and then cause the aortic valve to close. Once that happens at the start of diastole, blood coming back to the aorta will come up against the aortic valve and then start to leak in, start to flow into our coronary arteries. So a few things here. The coronary arteries receive their blood flow during diastole, ventricular diastole, and the diastolic pressure on your blood pressure is the pressure that they're likely experiencing. So when we talk about blood pressures, 120 over 80, right, a fraction, the systolic value is telling you the force of contraction, specifically the left ventricles, for the way that we measure it, as it's going through the body. And then the diastolic value is the pressure that's in the tanks, right? So systolic value, blood going out of the ventricles into the aorta. Diastolic value, blood resting and relaxing. So the reason we spend so much time focusing on the diastolic number in cardiac health is to say that our coronary arteries are really not supposed to get the same pressure that all the other arteries get, right? They're pretty sensitive, they're small, they don't have lots of layers because they're directly on the other side as cells that need them. They're not traveling through weird areas of the body that need protection. So they're fragile, I guess we could say. When patients have high diastolic values, above 90 millimeters of mercury, that's added stress that is now making it more likely that things like arteriosclerosis and problems with blood vessels in the coronary arteries can occur when that pressure goes up. So it's not, we focus a lot on the systolic value in emergency medicine. This is one of the cases where the diastolic value is important because the diastolic pressure is the pressure that these cells in the blood vessels are experiencing. All right, now this is a lot. And in fact, I'm going to kind of do it as if we're projecting this in class. This is a diagram that I took from the Human Systems textbook. You can go back and view it if you want to. The point here is not to memorize this document, but we have enough information in the background leading to this that we've been through. And we're currently talking about these things in assessment and about to put pieces together in electrophysiology. So this is a really good reminder of what was showed here. Now, I showed this to you in Human Systems and said, this is kind of where we're going to be going with this information, but it shows everything that happens, primarily, most of the things that happen inside a heart during the entire cardiac cycle, electrically, physically, sounds, all of it. So let me take some time and go through this, orient yourself to it, because again, if you're a visual learner, this might be a diagram that helps drive home some of the points of blood flow, which valves open and close, so on and so forth. And again, you've seen this before, it's from the Human Systems textbook. This shouldn't be necessarily memorized, but if it helps you put these pieces together, excellent. Let's start at the top. So at the top of this, we can see we've got our ECG, right? So we've got our one ECG, one electrical chemical cycle spread across the center of this. And then at the end of it, we have the start of the next one. Just below it, we have an area where it's showing the heart sounds and when they occur. The bands that we see here of colors that are going up and down, these bands just kind of help you line up phases of circulation that are at the very, very bottom, the blood flow of the heart. The area of pressure with multiple multicolored waves in it is showing you, as if we put a measurement device in each of these blood vessels, what the pressure would be in each of those locations. And the hospital could do that, and we could monitor that, so it could happen. But this is more along the lines of flight medicine if we're monitoring these things. This is showing not pressure, but the actual volume of the ventricle. And for our purposes, we'll just focus on the left ventricle. At the very bottom, it shows the atrioventricular valves and what they're doing at each moment in time. So it shows when they're open and closed. And that should line up with our heart sounds, because heart sounds are the closing of valves, right? That's the sound we hear, is the closing of valve, then like transmitting through the blood in that chamber so that we could hear it with our stethoscope. And then finally, the phases here are a little bit different than the phases we've used in other areas like phase 0, 1 through 4. These are not something you should memorize. If you want to look at them, they're only to line up with each step. More importantly, though, look at the pictures and see where blood is going for each of these portions of something occurring. So what you want to be able to do is, from the top down, be able to follow and say, when this happens, and visually you can see what that means. So let's go through a couple of points. I'll describe the whole diagram here for you, for those that need that information to drive it home, but otherwise it'll be reference point. All right, so the P wave occurring. The P wave happens when the SA node's depolarized. The SA node depolarizes, electricity goes down the atria of the heart, right? So it starts at the top, moves down to the top right, and then across to the top left, and it goes down the rest of the atria and stops at the AV node and stops moving downward to the heart because of the connective tissue in the atrioventricular valves. If we follow the P wave straight down, the next thing that we see associated with it is this purple and what is this bluish color waveform. So this is pressure. This is showing what happens to the pressure in the purple line inside the atria. And I'm sorry, the purple line is inside purple line is inside the atria. The blue line is inside the ventricle. So when the P wave occurs, if electrically and mechanically are working together, meaning we have electricity and a squeeze, if the P wave is tied to causing contraction, the atria will squeeze. When the atria squeeze, they get smaller, and that means that the stuff inside of it will go under pressure. So we end up with a little kick of pressure that wasn't there before we started the P wave firing. That kick of pressure in the atria will occur when the AV valves are still open, because blood is passively draining into the ventricles. So atria squeeze, ventricle stays still. That does a lot for our patient. So this is really called the atrial kick. So the atrial kick is when the atria squeezes and the ventricle stays momentarily still. They don't squeeze at the same time. That would be not good for us. The atria squeezes while the ventricle is still filling with blood. Before the atria squeeze, blood was coming from the vena cava into the atria and then just draining straight down by gravity, most likely, into the ventricle. That's not going to be enough to make the ventricle stretch. It just kind of fills the size of the ventricle. But when the atria squeezes and the AV valve is open, that sends an extra gush of blood, an increased pressure of blood here, the atrial kick, and that causes the ventricle to overfill. And if it overfills, now it stretches. And why is that important for our patient's blood pressure? Well, remember, preload is not just fluid returning to the heart. That's one part of preload, right? So I got to have adequate fluid going back to the heart, draining passively into the ventricle to go anywhere when the ventricle squeezes. But I can also recruit the effects of the rubber band theory, Frank Starling's law, in which if I have stretch, I'll have a proportionate rebound effect of contraction. So the more stretch, the more rebound contraction. So the ventricles were just sitting there, filling with blood passively before the P wave. P wave happens, atria fire, atrial kick occurs, increases pressure in the atria, also increases pressure in the ventricles and volume, and causes the ventricles to stretch a little bit. So when they rebound, they get the effect of Starling's law, okay? Now, the next graph shows ventricular volume. So this isn't pressure, it's the amount of blood in the ventricle. So as the P wave, as the heart is still between the last beat and this P wave, blood is passively filling the ventricle. So you can see it slowly going up. Here's the last one, slowly going up after the empty. And then this little notch here, this notch is the atrial kick. So that's when the atria squeeze from the P wave firing. and that causes a little bit more blood volume to go in. And again, this isn't about the volume though. If you notice, it's a very small amount of volume that gets sent in there. It's about the pressure, because the pressure and volume will give us the stretch. That's the benefit we get. So we get the pressure, we get the volume, a little bit of volume, lots of pressure, lots of stretch. And at the end of diastole, the end of the ventricle waiting, we have as much blood as that ventricle is going to take and hopefully rebound pressure with it. So preload has increased. If we follow this down with our P wave, during the P wave firing, nothing really happens with valves. They're in their position from before. So the atrioventricular valves will both be open, so blood can go from the top down. The semilunar valves will both be closed, so that blood's not going backwards into the ventricle, because that would lessen the pressure in the lungs and in the system. So those valves should be closed, but the AV valves will be open. Atria squeezes, AV valves stay open, so the atrial kick will affect. And at the end of the atria squeezing, now we're probably ready for the ventricles to squeeze, okay? So during the atrial kick, atrioventricular valves are open and our semilunar valves are closed. And again, the sound that we hear with the particles is the sound of the valves closing, transmitted through that chamber. So our first sound, S1, or the lub, the first sound happens when our atrioventricular valves close, and at the same time that we don't hear it, the semilunar valves open. So let's move down to the QRS. So the QRS in total, it's not really wave by wave here, but the QRS in total is where our ventricles contract. So we see the QRS depolarizing. This happens at the same time because once the ventricles depolarize, they're going to squeeze. The squeeze of the ventricles is going to lessen the pressure that's holding the AV valves open, because remember, they're tied to the ventricles, the papillary muscle and the chordae tendineae. So once the ventricles kind of get smaller, those valves will close. The atrioventricular valve closes, we hear S1, that's the lub sound, and it happens during the QRS. As that occurs and the AV valves close, we see a little change to the atrial pressure. We get a little bump of atrial pressure because when the valves close, blood's coming in but not going anywhere in the atria. This is momentarily while the ventricles are closing. So the atria really get a little bump here because of the valve closing, and then wait for the valve to open, and then they'll just rush again. But you can see here the pressure in the ventricle changes dramatically. The ventricle had the atrial kick here on this blue line, and then once the valve, the ventricle squeeze, QRS depolarizes, valve closes, blood now is sent from the bottom up and into the semilunar valves to go into the pulmonary circulation and the aorta. So we can see here the pressure goes up, 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 up until a peak. That's the peak pressure of the ventricle squeezing. And then once the peak goes downward, the ventricle is starting to relax, okay? Also, let's look at the volume of blood inside the ventricle. So the EDV here versus ESV stands for end diastolic volume and end systolic volume, okay? So at the end of diastole, the end of the ventricle relaxing, the atria have finished squeezing. Now the ventricles are squeezing and the AV valves are closing. We hear the sound. The ventricle is going to squeeze as much blood as it can, but not all of the blood out of it. There's still some nooks and crannies that some blood will remain. As blood is ejected from the ventricle, the volume goes down. Makes sense, right? The difference between end systolic volume, if you could measure that, and end diastolic volume is stroke volume. In most patients, it's 70 milliliters, 70 milliliters on the average. And you can see that's about what this lines up to, but it won't go to zero. There'll still be some residual blood left in the ventricles after squeezing. So as the volume is being ejected, that was because the ventricle squeezed and got smaller. The pressure in the ventricle goes up until the ventricle starts to relax and goes into diastole, okay? Now, during the ventricle's squeezing, the AV valves have to be closed or blood would go back into the atria and we would lose pressure. The semilunar valves have to be open so blood can go into the next circuit. And then as the ventricle relaxes, blood goes back through those vessels, the pulmonary and aortic circulation, and then catches the valve and closes it. So the second sound, the dub or S2, occurs when the AV valves are basically, the AV valves are opening and we hear the close with S2 of our semilunar valves. That happens during the repolarization phase of the electrical cycle of the ventricle. That's our T wave. Question for you. The atria depolarize, right? they have to repolarize. QRSs are ventricles depolarizing. T wave is the ventricle repolarizing. Where is the waveform for atrial repolarization? Is there one? There would be. So it's hidden though, because the mass of muscle that makes up the atria is so small that when it repolarizes, we can't see it because the mass of the ventricles depolarizing is way more energy. So it's kind of buried behind the QRS. So if there was a way we could see it, it does happen, but it happens when the QRS is depolarizing, the atria are repolarizing. All right, so on our waveform here, we have our T wave. That's ventricles have already done their squeezing. They're getting ready for the next beat. In this process, as the ventricles empty, their pressure will continually go back down until we get to baseline, where they'll start to fill again, very passive, until the ventricle squeezes, and that's where we see the pressure go up. So you can see pressure kind of goes down for a little bit till the atrial kick, and then it goes up as the ventricle closes. Let's look at this green line here. This is the aorta. So the aorta, this would imagine you have a lead that you're placing a measurement device that's measuring the pressure in the aorta right after the aortic valve, like where we saw the picture of coronary circulation from the cath lab. That is where we would put this device to measure it. That's where we're measuring. All right, so let's look actually from the last beat to start here. So here's the last beat, and then we'll come back over here. You can see that the aorta has pressure in it constantly, pretty high pressure compared to all the other areas. Makes sense, right? It's an artery, moving forward, flowing fluid. The pressure from the last beat will continually, steadily decline as blood goes back up against the valve, goes into the coronary arteries, right? That takes some blood volume out, and it's losing pressure as blood goes in all the other arteries for systemic circulation as well, and that is back pressure that it has. So the pressure is continually going down after the valve has opened. I'm sorry, the valve closes again. Valves closed, right, during all this phase. So P wave happens. That's atria. The aorta is not doing anything. Valve's just hanging out, closed, waiting for the ventricles to open. Close, close, closed. When the ventricle squeezes at the very onset, the ventricle will squeeze, and for a few milliseconds, the aortic valve will remain closed. And when that happens, it causes the pressure in the ventricle to go up, and you get a little bit extra stretch from Starling's law right before the valve opens. When the valve opens, we're kind of well into the ventricle squeezing. You can see here, the valve doesn't open until this point here, right after the first sound. And you can see that's lining up with when the volume is ejecting out of the ventricle as well. So the line goes up proportionally because the pressure inside the ventricle will become the pressure in the aorta, right? Same pressures. So that pressure goes up with the ventricular pressure. And as the pressure starts to alleviate, when the ventricle is now emptied as much as it's going to and it's getting ready to relax, blood will come back and lock that aortic valve closed. The dicrotic notch is what we see as a representation of that valve closing. Because remember, the blood's going into the aorta, so pressure goes up. And then once the ventricle starts to relax, blood instantly starts going back towards the ventricle from the aorta. It's going to slide back. That sliding back is what closes the valve. So it happens that we have a little bit of back pressure before the valve closes. And so we can see the decline in the aortic pressure until the valve closes. And then once the valve closed, the back pressure comes up against the valve, and momentarily we get another spike and the pressure goes down. Interestingly enough, for critical care and flight medicine, patients might have such a weak aortic valve and heart in general that they need help closing that valve off, where the blood just goes back into the heart and regurgitates, and they have congestive heart failure and probably cardiogenic shock. When we transport patients as a flight medic or critical care ground medic, you might have to monitor a balloon pump. And the balloon pump sits inside the aorta. This is extra info, so tune me out if you want to, but the balloon pump sits with a balloon inside the aorta that's perfectly timed, so that when the aortic valve is supposed to be closed, the balloon inflates, pushing the valve closed and preventing blood from leaking either direction. But the valve has to open when the aortic valve, or the balloon has to open when the aortic valve opens, or blood flow won't happen. So if we mistime this, the patient's not going to get any blood out of their heart, unfortunately. Certainly it will cause some damage to the heart, but they've got a lot to worry about already. So we have to time the balloon pump when we're operating it as a medic. And it's not as though, like when I've flown with them, you have a nurse there to help you, but it's not like someone flew there to operate the pump. You know, we operated the pump during our flight. So we had to make sure that it stayed timed, and we were monitoring aortic pressure, timing the dicrotic notch with the ECG, so that we knew the balloon was opening and closing at the right time and not causing worse problems for this patient. So what would I like you to do with this? I would like you to, as we're going through this term, come back and look at this to remind yourself as to how all these things are lining up. And again, very quickly, these things happen, you know, instantly and over a short period of time, instantly up and down, short period of time on length, that it's extended a little bit so we can visualize it and see it. But this hopefully helps drive home how all these pieces come together in our assessment and physiology of the heart. All right, good. Let me exit this. That's what I really had from our cardiac lecture from human systems to bridge that gap. To finish up though, I'm going to go back here and we'll talk about some assessment stuff. This is in module 4 for cardiac assessment. Again, pretty brief, but I don't want you to think that it's something you just download and don't do anything with. What I'd like you to do, though I'm not grading you on, is actively think about how you're going to make your own style of cardiac assessment. So it's not presented to you in this way, but if you're the type of student who really does well with like branched thinking with algorithms and flowcharts, make an algorithm out of this information between this and the things you're reading from the chapter, and kind of make an algorithm for your cardiac assessment. When you're assessing the patient, you hopefully will have that in mind so that if something like, if a patient answers this question, what do I do with it? Where do I go with it? That's one way you could use it. Or you can just organize how you use your high value stuff in your primary versus your secondary assessment, or on scene versus transport. Now, certainly with cardiac patients and most medical patients, I think this would apply to, we have the challenge like we did in trauma where we do want to get off scene quickly with critical patients because definitive care is not us. We don't carry it with us. They need to go to the hospital to get those things done. But in the medical world, a few things might prevent us from making a clean break like we did in trauma, okay? In trauma, last term, we taught you that you should really not get a blood pressure on a critical trauma patient on scene. It's not a great tool to give you information that you really need at that moment in time. It'll slow you down from transporting. It's error prone on scene because everything's very loud. That thing doesn't really exist. We don't really have a list that says, don't do this thing on cardiac patients on scene. It's a very big gray area. It may be that I have a critical cardiac patient, but I need to give some medicine before we leave, which means maybe it's an IV med. So I have to start an IV to give it. We commonly have to do a little bit more assessment in medical patients on scene to figure out what their problem is before we know enough as to say, you'll probably know if they're sick or not because the doorway view will work for this. But again, it's not like there's a list that says, do these things on scene, do these things in transport. And that can be frustrating for you as a student. I get it. So where you can make a list, totally do it. So first, let's talk about the document here. This is pertinent positive and negatives. Hopefully you've seen this before. It should be what you referenced in your medical classes last term as well. And although this is cardiac, it doesn't really mean that you can just focus on the cardiac section. Because again, when you're doing this in the initial phase of your assessment, you are asking questions and following tangents as you get them to start getting an idea as to which system you're focusing on. And then you'll do your review of those systems. But at the beginning, you don't know it's cardiac, right? So make sure you review all of this, but notice that cardiac and pulmonary, you basically always do together. If you are doing the pulmonary pertinent positive and negatives, you also need to do the cardiac pertinent positive and negative. Again, that big picture I showed at the beginning is that everything is stacked together in the chest and we can't always differentiate and tell it apart very easily in our assessments. But once you've figured out that it is a cardiac call, then you'll focus on these questions, or for other things, if you figured out it's a GI call or GU call, then you go down the list of pertinent positives and negatives. And before we get into the details of each one, remember that pertinent positive and negatives need to be memorized. They become your secondary assessment at the very least, and they're chartable too. So pertinent positives and negatives mean that regardless of whether it's present, regardless of whether they have this thing, it's important that we assess for it. And if they don't have it, it could equally be as important to our information as if they do. When you're charting these, where would you put your positives and negatives? So if you want to look at the cardiac list here, if you haven't done so all that, like where would you put the response to asking the patient if they're nauseous and have been vomiting in your D chart? Okay, so generally, I would advocate for you to place this information into the history section, specifically probably in your history of present illness, HPI. One of the reasons that we do that is because the history section is for subjective information. The assessment section is objective information, right? Like I can see, I can assess, I can get this information without them telling me. That's generally what goes in the assessment section. Although you'll get the assessment done when you're physically with them, it should go when you have pertinent positive information that's subjective. The patient has to report it to you, otherwise we wouldn't necessarily know. That information should go as part of your history of present illness. And again, make sure it's clear whether or not these things are present. Again, the rule is if you don't write it down, it didn't happen. So we assume that if you didn't write down that it was absent, that you didn't ask the question, not that it was absent. So you do have to document that it's absent. Okay, so pertinent positives and negatives. So students ask sometimes like, hey, I'm thinking of cardiac. Where is the cardiac secondary assessment list? There kind of isn't one. The secondary assessment is generally going to be a review of systems. The review of systems has in it pertinent positives and negatives. Here's your pertinent positives and negatives. But your cardiac assessment should be the assessment sheet that we give you in lab that's like 8 pages long. That's the entire assessment. You have to navigate between your resources, your patient condition, your transport time, which things you do primary and secondary. And like that's part of the practice of doing this stuff in lab. But you got to have those pieces in total in your brain. And then you're actively, strategically using your critical thinking to figure out how to put the pieces together in your question, okay? So let's talk about those high value questions. So if my patient has a complaint of the chest at all, pain, discomfort, or an injury of the chest, the upper neck, or the high abdomen, and again, 360 degrees around, I'll always listen to lung sounds in my primary assessment because it's a high value. I'll always ask about coughs in my primary assessment because it's high value and follow up those questions on the cough. And then I might do other things like an ECG might get moved to the primary assessment of a cardiac patient, obviously. Now, when it says cardiac plus pulmonary questions or pulmonary plus cardiac questions, that really is along the lines of when a patient says they have a hard time breathing, then it's very likely it's got some component in the chest, and the two major components in the chest are the respiratory and the cardiovascular system. So I would make a habit of memorizing them all together, though knowing strategically which ones you might dive into more depth on in cardiac, okay? So let's go through the cardiac stuff. So asking about chest pain, peek your STU to follow it up. Ask those questions about quality, about radiation, time of onset, and note what they tell you because line that up with the clinical definition of what signs and symptoms will be with different diseases. For example, angina and AMI, acute myocardial infarct, both have two different lists of similar, but they have some differences in how they present, right? Onset usually is not exertional for an AMI, where with angina, it is exertional, those types of things. Shortness of breath, dyspnea. So something that I want you to do, and if you're taking the respiratory class this term, or you've taken it, I think you take it either this term or the term before. With the respiratory class, I want you to pay attention to the process of a patient going through respiratory distress. Okay, so this is an ENT basic concept that we taught you, but it might be something you need to dust off. But pay attention to the different signs and symptoms that present when patients are in respiratory distress, respiratory failure, and respiratory arrest. Because if patients go through those things and end up in respiratory failure, they stop breathing, they're going to go into cardiac failure, right? Cardiac arrest after that. If not mitigated, a patient's problem breathing will progress through those things reliably. What's not reliable is what stage are they in when you show up and how long will they be in each stage? And mostly for adults. For kids, we'll view this next term, and there are some differences, but for adults, get to know that pattern. The pattern is something along the lines of patients that are in respiratory distress still seem to have the energy to get through their breathing. When they get to respiratory failure before arrest, respiratory failure is like they're failing. They haven't stopped. They haven't failed yet. Arrest is like they failed. They stopped breathing. During the failure phase, that's when patients are tired of breathing, when they show air hunger, just like in their eyes, when their accessory muscles are being utilized. When you find patients in those different stages, part of your job, whether it's a cardiac call or not, is to recognize which respiratory stage they're in and manage appropriately to prevent them from going to the next stage. If everything was lining up perfectly, we would arrive to patients in respiratory distress and they'd never get to respiratory failure in our care because we recognize it, we give them the oxygen ventilation support they need, and they wouldn't go any further. But as you know, that's not how this lines up. You'll land on a patient who maybe is in the end of the respiratory failure phase as soon as you arrive and just about to arrest. And those patients certainly were already behind the curve. They're already desatted. They've already got some damage from hypoxia. So recognize the types of shortness of breath and where they're at and signs and symptoms. And most of that's covered in the assessment block from respiratory, because again, it translates here. Patients that have heart attacks may have no respiratory problem at all, but they'll have the stages of respiratory distress as described as they decline. Nausea and vomiting. Why is it that patients that have a heart attack often are nauseous and in some cases vomit? Why is that? Pathophysiologically. Think about it. Pause the video, give it some thought, come back with an answer. Well, it's because they're in a sympathetic state. And if they are recognized, their body recognizes, hey, I might be dying from a heart attack. Like, I don't feel so good, right? If they're critical, they have those things going on, whatever their mix is, the patient's body recognizes it. When the sympathetic nervous system kicks in, they stop processing food through their GI tract, and that results in patients being nauseous. Now, they might poop themselves, right? But that's not necessarily like an indication that their GI tract's working. That's just what they had kind of in the pooper at that moment in time. The body said, let's just get rid of it. But everything else stops so we can send blood to everything else that's important in our body. So nausea and vomiting, pertinent, because it commonly is present. If it's not present, it's worth noting. So we have to note that they deny. Palpitations, you probably know this, but is the way a patient describes tachycardia. They feel like their heart is beating really fast in their chest. If we assessed them, we would not feel palpitations, right? Like palpitations is subjective to the patient. Don't get me wrong, they're real. But if we noticed it, we'd probably feel tachycardia when palpating their pulse, not palpitations necessarily. Coronary artery disease itself is a very big risk factor for almost all the cardiac conditions that we're going to talk about. Many dysrhythmias are based on it, so understanding that in the history is helpful. Dizziness, and just so you know, make a connection between dizziness and syncope. Although they're not lined up here, make that connection. So why do patients get dizzy in cardiac problems? What's the pathophysiology there? Well, there's many variations to get there, but dizziness is probably because the patient has a decreased perfusion and or hypoxia. And so essentially like decreased perfusion, like they're in the early stages or late stages of shock. So dizziness is a worrying sign in our patients, and pay attention to, does that dizziness change when they stand up or sit down or transition from those positions? Cough, again, high value question. Follow up with what type of sputum they're producing, because that can help us narrow down the problem as well. Again, patients can have multiple things. They could have a respiratory problem and experiencing a heart attack at the same time. But when we're trying to learn them independently, it's helpful to kind of exclude it. So for your scenarios, your plain Jane, straight up, there's one problem to fix scenarios, then you'll probably be investigating. If they don't have a cough at all, then it might be another thing that helps you preclude that they have a respiratory issue. Syncope and loss of consciousness. So when patients have syncopal episodes, aside from the very, like if you think of an emergency, very low level emergency of hyperventilation because of a psychological issue, aside from that, all syncope in your patients is a heart problem, and you need to be worried about it. At the EMT basic level, you got some training for heart attacks along the lines of heart attacks present this way, right? The pain, the location, the radiation, except when they're silent. And silent heart attacks happen in female patients, patients that are very old, and patients that have some problem with their nerves, basically like a diabetic, who don't perceive pain the same way, right? So when patients are female, in the age range that they could have a heart attack, if they have a syncopal episode, for our purposes, and this should have been taught to you at the basic level, it should be considered a problem with their heart until proven otherwise. When patients have syncopal episodes, aside again from that instant when the patient has, you know, a psychological emergency and hyperventilation, and again, even then, explore to make sure it's not a cardiac problem. Don't write it off just because you have the anxiety part of it present. Assess for the cardiac presence, but we're most worried about syncope being associated with a patient passing out because of hypoperfusion, inadequate perfusion, things along those lines, i.e., essentially the effects of shock. Swelling the ankles is a very good cardiac assessment tool. You're probably, aware to some degree of this, but how you use it, how you chart it. Generally, patients might have swelling throughout their whole body or in specific areas, right? Systemic swelling, as it's related to a cardiac patient, meaning everywhere is swollen, is probably associated with one type of heart failure. Which side, right or left, would cause systemic edema? Good, so that's probably right-sided congestive heart failure, right-sided heart attack, right-sided heart failure, where the patient's right ventricle is sick and dead, and blood is coming to it from the body, but it's not strong enough to send it to the rest of the body. So the blood gets stuck here and backs up in the rest of the system. So that might be one presentation you have. Otherwise, though, when we're looking at swelling in cardiac patients, we want to assess the lower extremities. And I'm going to use a couple terms here that are kind of describing, at least for our purposes, the same thing. They would be distinctly different if you read about them in a textbook. For our purposes, though, they're pretty much the same. So swelling in the ankles is to give us a little bit of a clue as to how well venous return to the heart is working. And so it could be that they have a right-sided heart problem, but they haven't reached failure and they don't have systemic full circulation edema. So this could be the early stages of their heart failing. So what ends up happening here when you assess the patient is you take their socks down or take their shoes off, and you assess the ankles and the feet for the presence of swelling. And you also assess whether or not there's pitting edema present as well. Now, when you come home from your lab days where you're wearing your uniform, you've got your EMT boots on, and you probably have some long socks underneath of them. When you come home from your lab day or from working or whatever, it's normal that when you take your socks off, there's an imprint of your socks on your leg, right? And even your leg might be a little bit thinner where the sock was holding all that stuff together. That's normal, right? Because you have compression, even with lower level socks. Not compression socks, you still have some compression, forcing blood to more easily evacuate that area. When you take your socks off, though, pretty quickly, that swelling should go away, and your leg should not have the little sock depression. It should just be your leg, right? In patients that have heart problems, they can't rebound. So they have all this extra fluid hanging out in their tissue. It's probably in the third space between cells and blood vessels. And when we assess them, the swelling is one thing, but then you want to follow up by, this is kind of like the sock test, I guess, but just faster for us to do. Take your gloved finger and push down where the swelling is on their lower leg. Could be their ankle, the upper or the lower portion of their lower leg, somewhere on the foot. Push in with your finger and remove it. Now, what we're doing here is testing for pitting edema. If they have so much swelling in that area, what will happen is it will take a long time for the fluid to go back into the tissue, and it kind of slowly drains, and we end up with a pit, your fingerprint basically imprinted into the patient's leg. Now, it's pretty easy to measure this and document. So if the patient does have edema and you push down, that would be called pitting edema. The pitting edema we measure in seconds. So the general measurement would be I push in and I take my finger out. I start counting 1 second, 2 seconds, and so on. If the pit goes back to normal within 1 second, then it would be +1 pitting edema. If the pit takes 2 seconds to go back to normal, +2. And the highest we'll count to is 4. If after 4 seconds, they have not had the pit return back to normal, then generally that would be +4 pitting edema and the worst that we're going to measure in the pre-hospital setting. And it certainly can go further beyond that, but for us, that's generally enough. With pitting edema, it's also worsened by the patient's reliance on gravity. So you could also hear dependent edema, in which the gravity is the dependent part. Dependent on gravity, blood is being pulled in the lower extremities, sitting in this area, and then not going back to the heart because of gravity. So when the patients have their feet down, their legs dangling down, that should make this edema worse. And elevating their legs will drain some fluid, but again, this is a long-term process in a lot of patients. It probably doesn't fix the problem for us. This can again tell us that we have basically not enough pressure returning to the heart, whether that's a heart problem or some other issue, and that generally is a poor finding. Orthopnea and PND, I believe in your second homework assignment, the cardiac assessment homework assignment, it's going to ask you for definitions of these things. So I'll quickly go through, but again, as I mentioned, have that thing out when you're going through your studying so you can fill it in as you go. Orthopnea itself just describes problems breathing when you're laying down. It's positional distress in breathing, right? Positional dyspnea. Generally, we see this in patients that say, when I lay flat, I have a hard time breathing. Could be that we find that out when we lay them flat in the back of the ambulance and they suddenly can't breathe, or they know this naturally on their own. Now, orthopnea, trouble breathing when you lay flat, happens because when the patient is laying flat, the length of their lungs and all the alveoli from top to bottom has much more surface area than just the bases do. So when a patient is sitting upright and they have blood in their lungs, the gravity will pull the blood into the bases of their lungs, and some of the alveoli up here should still work. So I'm kind of sacrificing and saying, if I sit upright, and these patients do it without knowing, they don't know any of this pathophysiology, they just know sitting upright makes me breathe easier. Blood will drain to the bases where it takes over less surface area. But when the patient lays flat, the same amount of blood is going to be distributed over a larger area from top to bottom, the length of the lungs, and more alveoli, and so they have more dyspnea associated with it. When patients realize this on their own, without a diagnosis, their response generally, especially if this happens while they're trying to sleep, is to prop themselves up on pillows at night to help facilitate drainage down into the lower regions of the lung. And they may even lay on a recliner, sleep on a recliner. So when we're assessing patients for postural nocturnal dyspnea, PND, we're basically assessing for the presence of their lifestyle accommodations. Again, no one told them to put extra pillows under their head. They just did it because they couldn't breathe, and that becomes their new norm. So ask patients, do you have problems when you lay flat? And again, use that as an indication as to how you should transport your patients. If patients have fluid in their lungs, do not lay them flat on the ground. That would make them not able to breathe, and you're going to have to fix it probably by first sitting them up. So pay attention to that clue. Listen to what they do to go to sleep. How many pillows? And pillows are all different sizes. You're really trying to get like how much elevation do they need? And think of it in as like degrees of sitting upright, right? Fowlers is degrees of sitting upright. We go from laying flat to 30 to 45 degrees. Semi-Fowlers, high Fowlers would be like 90 degrees. Try and figure out where are they in those degrees in their description of how many pillows or whether they're sleeping on a recliner to get a clue as to the backup of fluid and the impact it has on them at night. And certainly they could also have problems breathing at night that aren't related to the fluid in their lungs, like sleep apnea. And those things have an impact on cardiovascular health as well. So that's the question, how many pillows and why it relates. Ask about previous cardiac history and dive into it when you have a chance, right? In the beginning, it's important. I know they've had a previous heart attack. If I don't have time right then and there to ask it, just make sure I come back at some point and ask, what happened? How many have you had? Do you know what blood vessel was occluded? What did they do? What was your intervention, right? There's a big difference between a patient having, although both bad, having something like a Roto-Rooter procedure done in the cath lab and having 4 blood vessels completely replaced from some other part in their body in a coronary artery bypass graft or a CABG. So just dive into that. Also ask about cardiovascular health that they're seeing with their patient, their physicians. You know, have you had stress tests? Like, have they gone to that level to see how healthy your heart is? Because if the patient says they have a healthy heart and you ask, like, have you had stress tests, all these things, and they're in that age, then they think they have a healthy heart, but they may not have actually a healthy heart as diagnosed by a physician until they've had those things, ECGs, stress tests, and so on. Then follow up with our pulmonary questions, which if you look at here on the other side, have very similar questions. Shortness of breath or dyspnea, cough, what's the productivity? Fever isn't present in a lot of our cardiac emergencies, but could be. You know, patients could have pleural effusion because of an infection in the pericardial sac, but again, probably not going to cause a lot of systemic fever. Pedal edema is really talking about what you're looking at here, looking at swelling of the ankles and so on. It is relevant, some of these questions for cardiac too, right? Like, what's their drug and trauma history? Do they smoke? Smoking has a dramatic impact on cardiovascular and coronary artery health. So these are all things that'll be very helpful in kind of piecing together. If you have time with your patients, your goal should be to get all of these pertinent positives and negatives asked in all patients of that condition. The only reason you're not getting all this information is because they physically can't answer or you had your hands full doing something else. But again, they're questions, so you can multitask. So really, patients that cannot answer, the only reason you wouldn't go through all of these questions in your cardiac assessment. All right, great. Last piece to hit in this section will be looking at the heart tones location image. I would have this open while I watch the heart tones video, but he does a great job describing and very visual, a great video for us to look at. This picture here shows all the areas of where valves are located and where we'll hear heart tones in our cardiac assessment. Now, at the very minimum, if you're listening to heart tones, you want to listen at the 5th intercostal space along the midclavicular line. That's what this right here says, okay? Now, at our level, a few things to keep in mind for heart tones. Heart tones can be helpful, but for us are very often not the clinical piece of information that tells you it's this versus that emergency. So they're a part of the picture. So they're not necessarily, it's not necessarily as important that we listen to every valve in every patient to get a clinical piece of information that might change how we manage our patients. If you need to hear more about every valve for some reason, then that's when you would use these other sites. But if not, and when you're just starting to listen to heart tones in your cardiac patient, listen over the apex of the heart. That's the fifth intercostal space, midclavicular line, in most patients that have the right heart orientation. When you're listening there at the apex of the heart, you will hear all the valves opening and closing, so you'll hear the heart sounds. But you're most, like in that position, you're most specifically ready to hear some of the problems with the mitral valve and to hear things like a heart murmur. The picture here shows these arrows to indicate, and the video will help explain this, to indicate that we listen in these areas not directly over the valves, but along their blood flow. Because what ends up happening is when the valve closes, the valve's closing in a chamber full of fluid, right? So when the valve closes, there's a sound wave that'll go through that fluid and the chamber helps amplify it. It's not like we're listening to lung sounds in the lungs where it's a wide open space and there's a lot of reverberation that can occur. The fluid can change, lessen the sound, if you will. So the pictures here show where you listen and the arrow shows where that is in relation to the actual valve. So here for our atrioventricular valve, the tricuspid valve between the right atria and ventricle, you can see that we don't listen directly over it, partially because it's also where the sternum is, and listening to the sternum isn't very helpful. But we listen as it transmits sound down the right ventricle, and we'll hear that right along the border of the sternum on the left side. So that's the orientation. When I listen to heart sounds, if I hear an abnormal heart sound, I might then follow up by going and listening to the valve that created that sound, right? And since our sounds are generally in healthy patients S1 and S2, so if I hear S1, if I hear S1, I probably want a problem with S1 rather, when I'm listening at the fifth intercostal space above the apex. If I hear a problem with S1, I'm probably going to want to listen to my atrioventricular valves. If I hear a problem with S2, then I probably want to listen to my semilunar valves, okay? Now, what is a murmur? What are these other sounds, S3, S4? When you're in lab, your lab proctor might break out for you our heart sound and lung sound generators. You're welcome to jump on and listen to those, but you can search the web and listen to sounds on YouTube and so on and get a feel for what you're listening to. The way that we approach this is similar to listening to lung sounds though. When we taught you listening to lung sounds at the EMT basic level, remember that we mentioned something along the lines of you got to listen to a lot of normal before you can ever dream of identifying abnormal. That's the same thing here. So now in your patients, if you haven't done this already, when you're assessing a patient and you're listening to lung sounds, even if you don't need to listen to heart tones, just sneak in some heart tones. They're not going to know the difference. They think you're still listening to lung sounds. So just sneak in a few extra seconds at the end to hear heart tones at the fifth intercostal space, midclavicular line, and get a sense for what do they sound like, especially in healthy patients. Because with heart sounds and murmurs, there's so many different sounds, and we're not going to be hearing them so often that we're going to be proficient in them. And they mean so many different things that for our purposes, what we want to be able to say is, I listened and it was normal, or it was abnormal. And then from there, we'll have to figure the other things of this patient out. But an abnormal heart sound by itself probably isn't changing our care. It probably isn't narrowing us down to a specific condition. So be able to identify normal and then be able to identify abnormal at the very least, okay? Once I've identified abnormal, I might follow up by listening to another sound. So if I hear a murmur, figure out where you want to listen, or listen to all of them if you need to get more information. Often murmurs are going to sound like slurs or whooshes to the closing of the valve, like you hear some extra whooshing occurring, that can be a murmur. Sometimes we hear valves that click more than once, so the click is a little weird. We can have valve closes that don't line up and we get two of one sound. So for example, that's what it's describing of a splitting S2. In the splitting S2, when the patient's taking a breath at the moment in time that you're listening, if that happens, then what ends up happening is S2 happens, but it's got two sounds to it. And what's happening there is usually when I hear S1, I hear both atrioventricular valves close at the same time. When I hear S2, I hear both semilunar valves close at the same time. If the patient is breathing at a specific point in time when I'm listening, kind of has to line up to perfect timing. If that happens, what ends up occurring is the breathing causes pressure on the heart and a little extra blood flow will come in. And that extra blood flow will make one of the valves of our semilunar valves close first, and the second will close a millisecond or so right after it. So that's a split S2. It's not an extra sound. It's not S3. It's just two S2s, I guess you can think of it. And there are videos online that you can listen to get an idea of it. So those are my sounds. Let me get my stethoscope. You might already know this, but since we're here, let's just do a good job about it. When we're listening to sounds with our stethoscope, for adults anyways, for the adult, I'm generally going to listen to lung sounds with this part of the stethoscope. So the bigger part of the stethoscope is called the diaphragm. The smaller part is called the bell. On some of them, they have a piece of plastic over it. On some of them, it's just an open bell. It's just kind of specific to the brand that you get. Won't have any major impact on how you're getting the quality of your listening. When I'm listening to lung sounds, the diaphragm is designed to pick up the frequency of sounds that lung sounds produce. The bell is designed for a different set of sound frequencies. And so in adults, the bell is best covering the frequencies that the heart sounds produce. So generally, we listen to heart sounds by listening to the bell of the diaphragm, of the stethoscope, and not the diaphragm. Now in kids, it's a little different. With kids, if you're using, an adult stethoscope, they do make neonate stethoscopes, they make infant stethoscopes. I sell them, but you don't need to buy them. You just need kind of one adult stethoscope. But if I'm using an adult stethoscope with a child, I might be listening because of the size of their chest, I might be listening to everything with the bell. That's fine. I would just use the bell side for heart tones in the pediatric patient as well. Another side note in pediatrics is that in very small kids, sometimes because of the size of our finger, and the size of the space between the bones and where their blood vessels are, it's very hard to feel a pulse. So in very small children, like neonates, premature babies that are born, if we think there's perfusion, but I need to get a heart rate, you can do so by just using your stethoscope, placing it over the fifth intercostal space, mid-clavicular line on that baby, and count their pulse. Now, I don't get the information of how strong their pulse is, tactile, right, like palpated, unfortunately, but I can get a heart rate from it. Just note that when you chart that, it would be an apical pulse. I listened to the pulse over the apex of the heart, apical pulse, to signify that you didn't feel it, but you did hear it. So another use of this device as well. Okay, so those are our sounds. So right now, like in lab, if you aren't working in the field and you don't have anyone you listen to your teammates in lab and get a feel for normal heart sounds. At the very least, listen at the apex, but again, feel around, listen all the different sites so you can hear how the valves change in their sound as well. All right. Okay, so I know this was kind of a wide-ranging video where we talked about some expectations and topics from the previous week's work, the previous module. We even went back in time to an old class that we took to review some prerequisite information, and then we ended up talking about our cardiac assessment. So for cardiac assessment, you're not going to see a whole lot of graded material. It's basically the stuff that's here will be part of the graded material in the next module, including cardiac homework assignment number 2, which walks you through some of the points here. So come back to this and use that form to fill out as you go through it. Read the chapters of information here to try and figure out how cardiac assessment might be done. But the work you need to do for yourself to translate this to lab and in the field that I'm not grading is to make a flow sheet when you're not in the lab that helps you put together how your cardiac assessment's organized. Because really, all of you have different ways of doing assessments right now, right? Like running a scenario, you all found a way that works for you. You got this far. So now you just have to find how do you put these pieces into the picture so that they'll be useful, they'll get done, importantly, and you'll be able to use them at the right time. Figuring out when to do them on a call, do I do it on scene, do I do it during transport, is a little harder. Just know that that's the gray area. Be flexible to the idea that I can't tell you when to do these things always. It depends. So for example, when I have a patient that has a dysrhythmia and that I have a medication to fix the dysrhythmia with, right, I probably need to do that on scene. But in order to give that med, I probably got to start an IV. I had to do an EKG to recognize it. So although I might want to leave scene, it might be very important that I fix their dysrhythmia right then and there. So I end up moving some stuff on scene, knowing that they're critical and I want to leave. And so we're not as hard on you in lab as like that 10 minutes that we had in trauma to stay on scene. But if you can get off scene with a medical critical patient in 10 minutes, you're rocking it. Just realize that it's not as simple as load and go, because there might be things I still have to do on scene to correctly treat, and certainly, of course, always assess my patients. Okay, if you have any questions this week, reach out to me. Happy to schedule some office hours with you. I'll send some more updates as we go through the week. But hopefully this video will get you set in place of physically sitting for a lecture for this week's content. Again, this week is mostly going to be reading from your textbook and then a couple resources we have here in Brightspace. Hope everyone's doing well. Stay safe out there, and we'll talk to you again soon. Bye, everybody.